Hey y'all, I'm going to give a brief overview of the assessment, diagnosis, and management of abdominal aortic aneurysms. The abdominal aorta is a major artery of blood flow to the body located in the retroperitoneal space. It's important to note that AAA is a multifactorial process that causes weakening of the vascular wall due to the breakdown of intravascular proteins, the elastin and collagen, causing the vascular wall to dilate, which we see here in this picture. The most common etiologies include proteases, which are enzymes that break down the elastin and collagen within the vascular wall. Inflammatory mediators, you most often see that with patients with atherosclerotic plaques or smokers. Genetic factors and stress across the wall, most often seen in hypertensive patients. It's important to note that the abdominal aorta is not considered an aneurysm unless the diameter is greater than 3 centimeters. And this picture is showing a fusiform aneurysm just above the bifurcation of the common iliacs. Most common risk factors for AAA include hypertension, smoking, males, increasing age, and family history. Other common causes include connective tissue disorders such as Marfan's and Ehlers-Danlos syndrome, which you'll see typically in your younger patients. Unruptured aneurysms are commonly asymptomatic and often found accidentally during imaging for unrelated causes. Symptomatic aneurysms may present with severe abdominal, back, flank, or pelvic pain. The pain experienced is related to the size and the location of the aneurysm and is typically described as a ripping or tearing sensation. Ruptured aneurysms will produce severe abdominal pain, which will be sudden in onset and maximal in intensity. Initially, patients may be hypertensive, but will usually progress to hypotension due to rapid loss of blood into the retroperitoneal space. In the event a patient presents with the symptoms suggestive of AAA, assess and reassess vital signs, paying special attention to hemodynamic stability. I put the ranges of normal here just as a simple reminder of what is normal and what to be paying attention to. Perform a thorough abdominal exam. Be sure to palpate for any abdominal masses or pulsations, and also pay attention to symmetry of upper and lower extremity pulses, as both of these may point to aortic disease process. To diagnose AAA, we'll need to see it. Abdominal ultrasound is most often utilized initially as a diagnostic and screening device. Abdominal ultrasounds are best utilized for asymptomatic patients with risk factors who you suspect may have an aneurysm, hemodynamically unstable patients suspected of AAA rupture, or for screening purposes. The USPSTF guidelines for AAA recommend a one-time screening for males ages 65 to 75 who have ever smoked. For hemodynamically stable patients highly suspected of having AAA, abdominal CT is recommended over the ultrasound. Abdominal CT will allow for more detailed evaluation of the aneurysm size and the status, whether that be ruptured or unruptured. CTA is the gold standard for assessment and diagnosis, as it will provide the most accurate measurement of the aneurysm diameter and morphology. In this picture, we see a preoperative CT scan with contrast showing ruptured AAA with contrast leak outside the aneurysm where the arrow is pointing. Management of the aneurysm is based on the diameter. What I want to note here is that it is not considered an aneurysm until it is greater than 3 centimeters, in which case the patient will need annual ultrasound. And also note that at an aneurysm diameter of 5.5 centimeters or greater, the patient is indicated for elective repair, whether that be via open or endovascular repair, which we'll talk about later on. Always manage comorbidities, hypertension, diabetes, hyperlipidemia. Make sure patient has appropriate follow-up with their primary care for these things. If the patient is not contraindicated, beta blockers, aspirin, and statins have all been proven to decrease the rate of aneurysm expansion and progression of the atherosclerotic plaque formation. Of course, smoking cessation is always talked about with all your patients who smoke. Cigarette smoke promotes vascular inflammation and plaque formation and puts these patients at a higher risk for aneurysm formation. And of course, lifestyle, you can talk about that with every single one of your patients. Surgery is the definitive treatment for AAA, whether it be done emergently or electively. I'm not going to go into great depth in differentiating the two methods, as that could probably be a lecture in and of itself. Just know that a lot that goes into the methods used for treatment and surgery has a lot to do with the individual patient, the location, morphology, size of the aneurysm, and also the experience of the surgical provider. So let's get started. The open surgical repair is performed under general anesthesia, in which an incision is made through the abdomen and a graft is sutured to the non-dilated vessels above and below the aneurysm. Whereas endovascular repair is minimally invasive procedure in which a stent graft is delivered through an accessed vessel, usually the common femoral artery, to line the dilated aortic aneurysm. Historically, open surgical repair was the method of choice for treating AAA. That is up until the early 1990s when endovascular repair was introduced. There's some studies out there that have shown a decrease in perioperative morbidity and mortality with the use of endovascular repair. This is possibly due to the less invasive approach and also the increasing experience in the performing procedure by the surgical providers. The major complications from surgery include myocardial infarction in up to 10% of patients who undergo open surgical repair, and post-operative gastrointestinal hemorrhage, which is most often seen in your endovascular repairs. Obviously, the risk of rupture will increase with the increasing diameter, as it shows here in a study done in 2014, which showed an aneurysm of 6 centimeters or greater had an annual 12% risk of rupture, and an aneurysm of 7 centimeters or greater had an annual 25% risk of rupture. People always talk about the 50% rule when it comes to aneurysm rupture, and what that means is approximately 50% of ruptured aneurysms are lethal prior to the patient making it to the hospital, while 50% of the patients who actually do make it to the hospital survive the surgical repair. So it really shows the lethalness of aneurysm rupture and the seriousness. And these are the resources I used in making this PowerPoint. Thank you all so much for listening.